question, we go to the next part, and that is surgery. And you all know when we do the surgery, when there is a progression, just now I think Parijat showed you that I got a call from Lucknow, and the guy says, sir, I am trained in such and such place, I will not name the place. And he said that, sir, I have done the laser, but it is progressing. But you saw the homeopathic laser. If you do the homeopathic laser, it will progress. Just saying that I have done it and it is still progressing. So what I am saying is the reasons for progression should be known. If you've done a full laser, the chances of progression is very less. It's still there. I will not say it is not there. Even in 4 or 5% of cases, we still find progression of the laser. The second reason is delayed referral or not referral. Recently, I got a case in Patna, and in Patna we have done a lot of workshops. Subhadra has done, I have done myself almost now 10-12 years back. And still there was a doctor's son was seen there, and he was in stage 5 and he was asking me. So all these things, delayed referral in one of this thing. And then the babies, who are going into traction retinal detachment, those babies who have never been screened earlier, and very sick babies. By very sick babies, I mean, the babies who were admitted in an ICU for a long time, babies who have had septicemia, babies who have had multiple transfusion. All these babies are prone to develop a very severe ROP. So their chances of development of progression of retinopathy of prematurity despite laser is very high. Now this is a very good, very what you call as a case, 37 weeks. Do you see this small reach here? Then see this at 40 weeks and see this at 48 weeks. Now this is the time one has to go for the surgery. And you should ask me a question, sir, you saw at this stage, then why didn't you do the laser? I could not do the laser because I asked the child to get the laser done. They didn't come. They came here, and when I asked them, the child fell sick, and they didn't come, and they came at this stage. What I'm saying is that you have to know the right time to do the laser. And if you do the laser, the results are wonderful. I can only tell you this. Stage 4, A and B, we already know. Both these stages we can do a lens sparing vitrectomy, but for B, maybe it is sometimes difficult when the retina is lifted or when there is too much of scar or too much of traction is there. Nevertheless, one has to try. And 23G, I use 23G, but some people also use 25G. It depends on your dexterity, on your experience and all that. But mind you, this is a very different game. This is not kind of routine vitreoretinal surgery where you are doing 25G surgery even for, retinal detachment. This is an entirely different ball game. And then stage 5, we obviously, 20G surgery. I also do 23G surgery now because of more dexterity, more experience and all. The only reason for doing 20G is because you get a wider area and you can, dissect the tissue there, scar tissue, and also remove all the traction which is there, which is usually in the periphery. It is very difficult to separate the scar tissue from below the attached retina. And basically this is a salvage surgery. This is not a surgery to, give something, a perfect vision kind of thing. And the indications are when there is an open funnel, when there is a bilateral stage 5, you want to give something to the child, something. And VR is not extinguished, and many times there is a posterior synecdoche, so you can't elicit the pupillary reaction. So pupillary reaction may not be that important indicator, but definitely these two are important. This also may not be that much important because in the late stages, sometimes it becomes difficult to get the visual evoked response. And how do we prepare? Of course, under general anesthesia, I just want to tell you, to get a good pediatric anesthetist is very difficult. It's very difficult, and especially for the neonates. Pediatric anesthetist may be there, but to give anesthesia to a neonate is very tough time. Luckily, I have now got one in Delhi. Of course, these investigations are there. Most important is the counseling. And it's very important. People come from very far place. They go to LV Prasad, to Subhadra, they go to Narendran, Ajay, and our passionate friend Anand, and they go with a lot of hopes. When they come to you, they say it seems that everything will be all right, because they don't know what exactly has happened inside. From outside it looks normal, from inside the whole damage is already done. So you must explain them that this is what it is. There is an anesthetic risk is there. There is a chances of very, very poor recovery is there. And this surgery is basically a salvage surgery, which may fetch something, for the child. And what is the idea? The idea of surgery is to give ambulatory vision, do the viscodissection, try to do as much as viscodissection, and also do not too much of cutting, because the retina is so close, so it's very difficult to, at times separate. And retinopexy is not required. Here are the instruments. Now I'll show you some cases. This is a 28-week child. This is the 1400 grams, and the child when came to me was 61 weeks. What is this here? This is a central traction, and this is the scar tissue which is there. The whole tissue is pulling the retina like this, and many times in the periphery you find bare choroid. The entire retina is here in your hand. Why the video is not running? Huh? Oh, it's working. It's not working here. So that's very good. If you can see, I can also see. So you see here, this is a 4B and this is a 23G surgery. And I need not tell you. Only important thing I want to tell you here is, where do you enter? Entering is very difficult. Something like Mahabharata you must have read. Abhimanyu knew how to enter, but he did not know how to come out. So the entering is, maybe 1.5 or sometimes 1.25 or maybe from 1.5 to 2 millimeter from the limbus. And then you go inside, do the vitrectomy, and try to separate the scar tissue as much as possible. You may not be able to remove everything in one go. Remember, and if you try to do this, you may damage the retina, and once you damage the retina, the whole story is finished. So you try to remove as much as possible. You can use the cutter sometimes. The problem is, you want more illumination. In that case, you have to have a fourth port rather. 3 ports are already there. So you can use the illumination from there, the chandelier, and then your both hands are free. One hand you can use the forceps, the other hand you can use the scissors. And then you do a peripheral vitrectomy, remove all the tractions which is there. And you do the air fluid exchange. The scar tissues in the center is I have left. This is the pre-operative, this is the post-operative. I have been able to clear the central scar tissue. Although small scar tissue is there left, we can do it in the second surgery. At least I have cleared the disc and the posterior pole, and this we can. This is another case. Another case, 28-week child, 48 grams, 61 weeks, and see this. You can see this a kind of a vertical scar which is pulling the retina. And again, many times it is very difficult to put the trocar and the cannula because the eye is small, and also because if you apply too much of pressure, you can go to the other side and damage the retina. So one has to be very careful. And see in this case, what do you see here? Huh? I have damaged the lens. So sometimes this may happen. And if the lens is touched, I think it's better to remove the lens. And then I am going ahead with the surgery. I am also doing pupilloplasty because I do the pupilloplasty because in children there is a lot, very many chances of, the fibrosis is there. Many times there will be a kind of a phimose pupil, and then it will be difficult for you to examine. So this is all scar tissue is there. This is the central part. See, this is the detached retina here. I'm using the This is a kind of a forceps I'm using and gripping. You can also use an ILM forceps. And try to remove the attachment with the vitreous. Once the vitreous is, traction is removed. Okay, this is another case in which I did 25G surgery, 30 weeks, and 1250 grams, 66 weeks. Can you see this? This is a traction here all over the posterior pole, and this is the scar tissue going to the periphery. And this must be attached anteriorly to the vitreous and the anterior halide. So this is a 25G. A long time back I did this surgery, maybe almost now 10 years back. And the 25G was invented first and 23G was invented later. 25G was invented somewhere around 2000, 2001. I was in Doheny Retina at that time. And this was, this was with the Bausch and Lomb, not with Alcon. And this is the picture like, and trying to remove as much as vitreous attachments are there. Once we remove the vitreous attachments, as you can see here, then we try to separate the scar tissue from the retina. But you have to be very careful so that you don't, neither you pull too much and nor you go too close to the retina so that, there's a retinotomy. So I've cleared almost the posterior pole. And then do the air fluid exchange. Then there is this is a 28 weeks child, 1160 grams and 62 weeks, and this is a stage 5 ROP in which 20G surgery was done. And of course 20G you have to, make a opening in the conjunctiva and go to the sclera. I go very close, maybe 1.5 from the limbus, and make the pass the sutures. And then of course the usual 20G vitrectomy. And as I told you, I do a papilloplasty, so that you have got a very big area to work on. And there's some bleeding also sometimes, so you can do the diathermy for these bleedings. Don't leave any bleeder, because if you leave the bleeder, later it may, result into a vitreous hemorrhage. And also many times you find that the child has been operated and the child has got hyphema. So I'm doing the diathermy. Trying to remove, there are a lot of adhesions, when you go deeper. When you have removed the anterior scar tissue, you go deep, you will be able to see the retina. And once you see the retina, you have to remove all the adhesions, all the traction points which are there. Now you can see the retinal vessels here. You can see the retina which is there. Take care of all the bleeders which are there. That's very important. You can see now very well, the funnel has been opened now, and you can see very well the posterior pole. You can see the disc here. So I think it's reasonably okay. And then you do the air fluid exchange. Unless you want to see this. I think we are short of time. 2 more lectures are there. So when do we stop? As I was telling you, that once anybody does any surgery, he should know when to start and when to stop. He is a good surgeon. Not one, who goes inside and then he goes on swimming and then ultimately he comes out of 2 hours. So not that thing. And when you find that the retina is mobile, if it is not mobile, at least you can see the retina and you have not done the retinotomy. And when there is a node retinal tear and you do the air fluid exchange, if you do a good air fluid exchange, you will be able to see that you have made the retina mobile. How much retina mobile, you will yourself know. Surgical results are there, various studies are there. So I want to give the message. And the message is that, as I think somebody said, Subhadra or Parijat or earlier discussion, that people say, I think Subhadra in the earlier session, that people say now it is stage 5 or stage 4, nothing can be done. That is not correct. You must tell, still some hope is there, and if the case is eligible for surgery, not all cases. If your baby is eligible for surgery, and if surgery is done, the vision can be salvaged. How much and how far, this you will leave to the retinal surgeon. So, and the most important thing is you have to have a good pediatric anesthetist. You have to be lucky for this. And also a good counseling of the parents. That's very important. So that was the last slide. And thank you very much for your kind attention.